Hello everyone, welcome to this PCR webinar. We are live from Paris and would like to speak about transcatheter tricuspid valve replacement. I am Fabien Prat, interventional cardiologist from Bern University Hospital. Warm welcome. This PCR has been organized in collaboration with the PCR Tricuspid Focus Group, and the goal of the webinar are to give you an update on the latest evidence supporting this innovative therapy, transcatheter tricuspid valve replacement. And there is a lot of news from the recent conferences and new publication as well. We would like also you to get familiar with approved transcatheter solution and to understand how to select patients for this therapy and what are the implications in terms of clinical management on your clinical practice. I am extremely happy to be surrounded by a fantastic panel. On my right, I have Tiffany Patterson from London. Hi, Tiffany.
Hi.
I have also Matti Adam from Cologne.
Hi.
Hi, Matti. Thank you for being here. And we have online the fantastic Philippe Lourdes from Mainz. Thank you very much, Philippe, for being with us as well online here in the studio in Paris. We would like to start by telling you that you are the important people in this webinar, and we would like to answer your question. And Tiffany will look at your question, ask question online, and we will give priority to this at any time in our discussion, also to be able to interact with you during this webinar. I would like to start by explaining you, and Tiffany will do this, why TR reduction is so important for our patient and why this can change also the clinical course of patients suffering from tricuspid regurgitation. Tiffany?
Thanks very much, Fabien. So I think we should think about what our ideal outcome is after a transcatheter tricuspid intervention, particularly for our patients. What do we want? Well, we really want symptom and quality of life improvement. That's an absolute. Ideally, in patients with right heart failure symptoms, we'd like some right ventricular reverse remodeling, prevention of heart failure rehospitalizations, and possibly a survival benefit as well. But what are we starting to see consistently is that reduction of TR grade down to moderate or less appears to have a greater impact on quality of life. And actually, we see a dose response with actually an increasing reduction in TR grade improves your quality of life score. This optimal result is also extended from TRILUMINATE into TRIFR, where we see a narrow interquartile range with an increasing TR grade reduction. Not surprisingly then, we also see symptom benefits as well. And patients with residual 1+ or less TR, a greater proportion of them will be in NYHA class 1 or 2, although we do see an increase in exercise capacity across the board in these patients. We also see right ventricular reverse remodeling, and consistently in those patients in whom we achieve an optimal result with residual TR grade 1+ or less, we see reduction in end systolic volumes that are quite marked and also end diastolic volumes. And there may even be a signal towards a survival benefit in these patients. And if we're achieving moderate or less tricuspid regurgitation and post-tricuspid valve intervention, there may well be that signal. And let's have a look at the patients with massive or torrential tricuspid regurgitation at baseline, and in particular, how the devices manage these patients. You can see in the top right graph with transcatheter tricuspid valve replacement, consistently we get an excellent result with TR, almost complete elimination in these patients. But TR perhaps is not the best strategy in these patients with massive or torrential tricuspid regurgitation, as we seem to achieve less precise results in these patients. Perhaps not the optimal, which is what we want. And why is that? I think we need to think about anatomical challenges, and the GLIDE score is a very good structured approach to how we approach that. And if we look, we can see that patients with a septolateral gap of greater than 6 millimeters, jet locations diffuse, star-shaped gap, all of these factors potentially may impact our result with TIR. And you can see in the trials, the first 5 trials are predominantly trials of tricuspid repair versus TRISCEND, which is tricuspid valve replacement. And patients with 1+ or less TR, we see that's achieved in 98% of patients with TTVR. But in the TIR trials, we achieve that maybe in about 50%. And with TTVR, actually that's sustained out to 2 years. So what are our take-home messages from this? Well, we see that a lower residual grade of tricuspid regurgitation post-intervention is associated with improved quality of life, symptoms, and exercise capacity. It really is important and helps reduce heart failure hospitalizations and has the potential to improve survival. If we look at tricuspid valve replacement as an option, we do get a greater reduction in tricuspid regurgitation that's sustained. It's probably preferable for those with massive torrential tricuspid regurgitation and those in challenging anatomy.
So thank you very much, Tiffany. That was an excellent summary of what we know about reducing tricuspid regurgitation. And obviously it does a lot, actually, even if we don't have a proof on benefit on survival yet in randomized controlled trial. We see that patients react in a positive way in terms of symptomatic improvement, but also that we have biological effect on right ventricular remodeling, improvement of renal failure, liver impairment as well, and that tricuspid regurgitation reduction is actually beneficial for the patient. There are many signs of this. So you have shown very ambitious goal for TR reduction, which may not have been always the same goal, in terms of going to mild or at least moderate. How do you make this possible in your practice?
Well, you're right, and we are aiming high now. We are really hoping to achieve the biggest TR reduction that we can get. And I think it's really about patient selection. So choosing the right device for the patient, being really careful, patient optimization is key here.
So, Matti, maybe to you as well, the same question. Our goal have changed. At some point, we were happy to have just one grade reduction because that was so technically challenging. But I think we are away from this now, and the strategy for our patient having different device is another one. Is that your experience as well?
Absolutely, and I think Tiffany made great points. So I think it's patient selection, preparation, and also diagnostic in the patients that you get referred. Glide score, for example, is super important. Or that knowing what other devices you have, maybe even do a CT scan early. I think we might touch on this later, so that you have all the information that you can actually decide the best way how to treat your patient.
I think very important point. Prepare the patient, admit the patient earlier, optimize medical treatment as well, and diuretics to have the patient in the best condition, and then choose the right device that gives you minimal complication, but the maximal reduction of tricuspid regurgitation. Very important change, I think, in the paradigm in terms of how you approach patient with TR. So now we would like to show you a case because we want to discuss some very concrete clinical situation. And we will move to Philippe Lourdes now for the first case from Mainz. Welcome.
Okay, very good. So it's my tremendous pleasure to present one of our patients. That patient is 67 years old, which in the world of tricuspid valve interventions means it's rather young. Which might also explain why he was clearly symptomatic, but not terribly symptomatic. But he lived a very active life and he couldn't do that anymore. He felt very limited due to his shortness of breath on exertion, and he also started to get some mild signs of right heart failure. He had quite extensive history, given the fact that he had cardiac surgery involving both aortic and mitral valve replacement, so mechanical valve implantation 10 years ago. He has single vessel coronary artery disease, AFib, and COPD. His lab results also indicated some signs of heart failure, renal function was preserved, and he had some signs of liver congestion. Here you can see the echo results, which revealed a preserved left ventricular ejection fraction, also preserved right ventricular function, given that TAPSE was 20 millimeters, and also more global assessment, AFC, indicated preserved RV function. Most importantly, there was significant tricuspid regurgitation, which was graded grade 5, meaning so there was torrential tricuspid regurgitation. Both mechanical valves, both in aortic and mitral positions, were found to work quite well. So although the risk score isn't that high, looking at Euroscore and TRISCEND, remember that that patient already underwent previous cardiac surgery. As we always do, also in that patient, we perform the right heart cath, indicating only mild increase in pulmonary artery pressures with low pressures on the left side and also low pulmonary vascular resistance. And we can have a look on our patient's echo views. And maybe we start on the bottom left, where you see a transgastric view, where a quite pronounced gap is seen extending from anteroseptal right to posteroseptal commissure. So these are certainly larger gaps. We see also regurgitance jet extending right from anteroseptal commissure across the entire commissure. And if we then go to the next slide, please, we get a better appreciation not only of the gaps in this X-plane bicommissural view. You can see that the gap might be obviously is there, but it is not terribly high in that illustration. But what is seen is that the mobility of the leaflets are slightly limited. So this is considered to be rheumatic tricuspid valve pathology. And with that, I give back to you.
So thank you very much, Philippe. Fantastic case. Maybe we can take some time to discuss a little bit, because it's a very particular and special history of this patient. So 69-year-old patient with rheumatic disease, two mechanical valve in position, huge tricuspid regurgitation, very big jet. And what is interesting as well, so you did, of course, a right heart catheterization, and we see that the pressure on the left side is actually quite good, with a wedge of 8 millimeter of mercury. So despite of this history, the treatment of the left side is really excellent. So one question, that when we see these images, obviously very good quality of images, why not doing, for example, edge-to-edge repair in this patient? What were you thinking in your discussion at your center, Philippe? Is this patient suitable?
Well, good question. Before we heard the glide score already, and what that entails is an assessment of the gap, considerations about the extent of the TR jet, also considerations about the fact about leaflet mobility. I think in terms of gap, it might be possible to do a TEER procedure, but remember that leaflet mobility was restricted. It's a rheumatic component to the disease. And I think when TEER is approached, TEER, you might end up both probably with a not completely satisfying result with respect to TR reduction, but probably also you will get a stenotic component.
And Philippe, were you worried about imaging quality because of these mechanical valves in place, or what were your thoughts on this? Obviously, the imaging looked great in the images you showed us, but is there something that you worry about?
Yeah, I think in these patients with mechanical valves, you have to do your pre-assessment very thoroughly and check about imaging quality. It's not easy to predict. It's more often that imaging quality is inferior in patients with mechanical valves, but as shown in that patient, it was actually pretty good. So we weren't too worried about imaging.
Philippe, I have a question as well. You alluded to TEER perhaps not being the best strategy here, which makes me think that you may be considering tricuspid valve replacement. In such a young patient, do you think ahead in terms of lifetime management, what the strategy would be if a valve replacement did degenerate?
Yeah, it's a very important question. Normally, we don't have to ask ourselves that question too often, because the mean age also in studies is a little bit less than 80 years. And here, the life expectancy is much longer. Although the experience is still limited, I wouldn't see a reason why we can't do a second intervention, implanting a second valve in a EVOQUE platform, as we have done in this case.
So Philippe, thank you very much. I think very clear argumentation as well. But maybe we can, obviously you have certainly discussed this younger patient in your heart team. But maybe at your institution, Matti, would you consider doing surgery in this patient? What would be your consideration?
Well, I mean, it's a young patient, so it's totally it's really important to discuss this patient in the heart team. But so I think this patient has no coronary artery disease. The mechanical valves on the left heart side are actually working fantastic. There is a lung disease, COPD, that I saw on this patient. And so I think this is not a patient that we would consider for redo surgery in our center. So I think that would be interventional treatment for us.
You know, obviously the data are very difficult in terms of redo surgery for isolated tricuspid regurgitation. On one side, we don't have so much studies, but on the other side, we know from historical data that this can be associated with significant mortality, because obviously these patients who have undergone already surgery have a risk of right ventricular failure. So I think at my institution it will be probably the same. And I think transcatheter therapy is an excellent therapy also in patients with rheumatic heart disease, and give you the opportunity to treat this patient in a minimal invasive way. But maybe Philip, maybe a more technical question. So you show us that there is some stenosis as well as this patient. So what was your thinking about the risk? We know that in some of these patients with stiff leaflet, with tricuspid stenosis, there could be a risk of malposition of the EVOQUE valve, for example, because it's a really complex anatomy. So what was your thinking there and your conversation with the patient regarding this and regarding the opportunity to convert if you have a complication? Is that something you discuss with the patient?
I mean, all eventualities should be discussed with the patient, obviously. In that case, we thought that because there is a rheumatic component to the pathology and because leaflet mobility was restricted, TIA might end up with a stenosis. But for replacement, we weren't too worried. It seemed that these leaflets would still give away and would allow a valve to be placed very safely and secured in the position we wanted to place. So actually, in all honesty, I wasn't worried about that.
Okay, excellent. So I think we have understood that you opted for transcatheter valve replacement. Maybe you can show us what you did, but also, you know, what kind of data support this treatment in that particular situation and that particular severity of TR.
Yes. Can you help me a little bit with the slides, please? Okay, perfect. So as said, we have chosen to perform replacement rather than repair for the reasons mentioned, but not only for the fact that TIA might end up with a stenosis, but also for the fact that we start off with torrential. We want to bring it down to mild, or better, even less. No TR is perfect. And we know that when we start with torrential, the likelihood of bringing it down even to moderate is already reduced, not to talk about mild. That's why we have chosen to go forward with replacement using the commercially available TTVR system, the EVOQUE system, which comes in 4 different sizes, 44, 48, 52, and 56 millimeters, which allows to treat the vast majority of patients unless they present really, really late. All sizes have a valve in the center with a diameter of 28 millimeter, and this is a transfemoral, transvenous system, 28 French. Next, please. For assessment of suitability, obviously echo is important, but also, and most importantly, also CT assessment to get the perimeter and the dimensions of the tricuspid valve annulus. But for more detailed MCT assessment, we will hear more about that later. Next, please. Okay, so what to expect? And there we have some new insights from a subgroup analysis of the TRISCEND II trial. The TRISCEND II trial was a randomized trial assessing the safety and effectiveness of the EVOQUE platform as compared to control group medical therapy only, 2-to-1 randomization. Overall, 400 patients were enrolled. And what we have done here, we've done an analysis according to the baseline TR severity. And if we go to the next slide, what we found was that in patients who started off with massive or torrential, and those are patients, if you look on the left, Kaplan-Meier curves with the solid lines, those who started off with massive and torrential in the control group, which is solid gray line, and had a quite high rate of heart failure hospitalization. And then those solid line in blue had certainly much less heart failure hospitalization events. So as long as baseline TR severity is massive or torrential, a clear signal, less heart failure hospitalizations with EVOQUE as compared to control. So we were very confident that we not only abolish TR, but we also will have will convey good results in terms of hard clinical endpoints. Next, please. Okay, now we come to the case, which you can start, please. So as said, first step using a stiff wire, in most cases a safari wire, which helps to advance and position the transfemoral transvenous system safely within the right ventricle. This isn't a tremendously difficult step, but it's an important step where one needs to make sure that the system is placed safely, and also the wire is always held in place, which should lie in the apex of the right ventricle, or more to the posturoseptal aspect of things, not to get entangled with a moderator band.
Any tips?
The system is then
Sorry to interrupt. Any tips and tricks to get that wire in that perfect position?
how one does that?
Sorry, do you have, well, go ahead. It's the case is going ahead, so I'll ask you later.
Yeah. So the most important bit is to be patient, and that's for the whole procedure. There is no time to rush. There is no time where you should expect any hemodynamic instability. The only thing is that you can only go forward. It's very difficult to go backward. So it's step by step in a very controlled and very stable manner, getting all the informations both from echo but also from fluoroscopy. The first step is to withdraw the capsule, and the capsule allows these 9 anchors, which are important for valve for safe anchoring, to unfold and flip. This is done exactly at the right level. What is the right level? Not too high, not too low. So underneath the leaflets, so the leaflets can come on top of these anchors, but also not too low, because then the risk is that the system could get entangled in the quite busy subvalvular apparatus. During all steps, as said, we use fluoroscopy and echocardiography. And on echocardiography, the most important view is with the echo probe being in the esophagus using an MPR reconstruction. And that MPR reconstruction allows us to appreciate whether all 9 anchors interact with the 3 leaflets.
So that's where Philippe, your echo support is very important. So basically, you are checking here that you don't miss any leaflet, that all leaflets are really on the device at that point. Is that correct?
This is absolutely correct. I mean, in all honesty, this procedure pretty much depends on imaging and on echocardiography, not so much on the interventionalist, but it's all about decision making, right? So all leaflets needs to be on the device, but even more important, ideally all 9 anchors must interact with the leaflet. It is possible to miss out 1 anchor, maybe in some instances also 2 anchors, but ideally not 2 anchors at the same position.
And what we see here is what we call the spinning. So your echo specialist is turning around the plane to be able to look at every of the single 9 anchors. Philippe, what is your level of freedom to correct if anything is going wrong in that situation?
So that it is possible to correct some things and go further.
Oh, I think we lost Philippe. But maybe we can stay on the live case, and Matthew and myself and Tiffany will comment a little bit. So what you see now is that the valve is slowly deployed. You see that we have flipped the valve already. Matthew, that's a position actually where you are less able to change, so you need to make sure you are in the right position at that moment, but still the valve is not completely implanted and you will be able to change.
It's really important now, I think, what Philip and the team are now focusing on with the anchors fully flipped and the valve already developed quite a bit, that they're really in the hinge points with the anchors so that the valve actually is in a high position when you release it, because especially in a rheumatic disease like that, you don't want the valve to migrate after you deploy it, right? So you really want to make sure you see the deployment right now with the atrial part of the EVOQUE being released now from the capsule. Now the valve is fully released, but it's really important to stay in a stable and really high position there, and echo helps there a lot. It's sometimes challenging to see, and you need a lot of interaction with your echo colleagues there.
That's a very important point. I mean, in particular in stenosis, I mean, you would agree, Tiffany, you need to implant high. And I think that's a rule for this implantation, to stay really high and make sure the anchor at really at the hinge point. You mentioned before one point, Matti, regarding the placement of the wire. Obviously, that's something that is a bit underestimated sometimes. How do you do it? And maybe Tiffany, you can also give your experience regarding this. That's the first step, but also one of the very important ones to ensure that the procedure is going smoothly.
Yeah, I mean, I think Philip set the tone when he said go slow in the beginning, especially. We use steerable sheath to really flip that safari wire. We also use safari wire only, but there might be people who have tried other things. But to really put that wire in a position that you're not interacting with the papillary muscle, that you're really in the apex. And I think EVOQUE here again helps a lot. You will see in fluoro if you're in a good position, but if you're in a perfect position, I think that's what EVOQUE tells you. How do you guys do it?
Yeah, I completely agree. Steerable sheath is what we use every time, and we try and always go up front with an extra small safari, try and position that posteriorly. Sometimes actually a pacing lead is a really good guide. If you have a look on the CTC where the pacing wire is positioned, you can actually work out where you want your safari to be in the ideal position. It saves a lot of time because you can often tell that in fluoro. You can then flip to an RAO view, which is a recommended view on CT, and just helps you establish that your wire is in a good position. Often there's some challenges with bringing the delivery system, with the wire movement, but generally it stays in position.
So Philippe is back. We were so we follow your fantastic implantation, of course, absolute perfect position in that challenging anatomy, I have to say. And we were having some technical consideration on wire placement, which is underestimated but important, I would say, as a first step. Maybe, Philippe, you can tell us how the patient did, because obviously we saw that the procedure was absolutely uneventful.
Yes, maybe we can have the slide for this. So the patient recovered very fast and also was doing much better. He was pretty much asymptomatic.
Wow.
Had no signs neither of left nor right heart failure afterwards. NT-proBNP improved. You can see that RV function was still preserved. These are echo images acquired 3 months after the procedure. We can see that the valve is perfectly functioning with no gradient and no residual TR. So with replacement, we don't talk about residual TR, but we can appreciate the fact that we abolished TR completely. So we were very satisfied with the result.
So congratulations, Philippe, on this case. And I think that's not a surprising result in terms of clinical response, because it's a young patient, very limited in terms of cardiac output by very severe TR. So this patient could have a huge benefit, actually, of this perfect reduction of tricuspid regurgitation, and even more that the left side and the valvular disease on the left side was perfectly corrected. So thank you very much. Impressive case. I just have one question, Philippe, regarding your data you presented and that have been published in the European Heart Journal by your group. How does this data, how do you explain them? Are we treating the right patient? And do these data have consequences on the way you select your patient now?
I think the most important information out of that analysis is that, yes, indeed, we can make a difference with respect to heart clinical endpoints. It's not just a symptomatic improvement, but we can reduce heart failure hospitalizations and potentially even change survival. But obviously, therefore, we have to wait a little bit longer and see what follow-up will tell us. And it isn't surprising that we get greater benefits in patients with massive and torrential, because as said, they benefit the most. Coming from torrential to no TR is a tremendous difference. It also doesn't mean that we shouldn't treat patients with severe TR, but it probably, and this is what we have seen in that analysis, you have to make sure that severe TR is truly severe TR. In the control group, there were a couple of patients, 25%, in whom TR improved. They had only moderate TR at follow-up. So I think when TR is really severe, then you should treat. But maybe if it's in between moderate to severe, then it's advisable to do another assessment, because we know that TR assessment depends also a little bit on volume status. and varies much more than with other valve pathologies.
Thank you, Philippe. Tiffany, we have time for one more question, I think.
Yes, so actually it's in part answered by Philippe and yourself, but we've got a question online asking, how do we predict a good outcome, and what's the key factors in predicting a good outcome from repair or replacement? And I think you alluded to that, particularly looking at the severity of the TR, massive or torrential, and also potentially the glide score, which we've mentioned already. I have a question for Philippe actually as well.
Yes.
While we're on the topic of this discussion, because that was such a perfect result, Philippe. It was a great result, great outcome in a young patient. It really matters, the follow-up in these patients and making sure they do well. And more specifically, the post-procedural management. How do you manage these patients post-procedure? Because you've invested so much in the case itself. How do you ensure a good outcome? And what is your anticoagulation strategy and next steps?
I think the key message here is that the job is not done with the procedure, right? So you have to make sure that the patient is doing fine, that the volume management is correct. You have to check for RV function. In that case, it wasn't a problem at all because he started with a preserved right ventricle. Conductance disturbances might be something which can occur. One has to account for that as well. These patients, especially when they are older, all have an increased baseline risk for bleeding. And as you said, anticoagulation is very important. These days, we leave them on whatever they came with. When they came with DOAC, we leave them on DOAC. When they are on warfarin, we leave them on warfarin, because in our experience, and also this is supported by evidence, the change is in what put patients at risk. It's not so much the question of whether it's DOAC or warfarin.
Thank you very much, Philippe. It was a great pleasure. You stay with us, of course, and we will look now at a completely other story, other case, but also a very frequent clinical scenario with Matti. Matti.
Yeah, thank you, Fabienne. It's my pleasure to present you this case. It's a little bit different, as Fabienne already alluded to. So I brought an 85-year-old male patient who presents with exertional dyspnea, NYHA class 2 to 3, who almost a little bit more than 2 years ago had been placed a ventricular pacemaker because of AV blockage 3rd degree. The percentage of ventricular pacing in this patient is actually 99%. The patient had undergone surgery before with the Paramount 25, is on permanent AFib, and therefore his medication obviously is fenprocomone. No coronary artery disease is known, and you see the lab work on the right-hand side of the screen. Chronic kidney disease with a GFR of between the 40s and 50s, some arterial hypertension, and a diabetes mellitus type 2. He was decompensated before, but he's pretty well recompensated right now. Bilirubin is 1.0, and all the other lab values seem okay. He has been hospitalized for cardiac decompensation, obviously not now, as you've seen, but he still complains about severe fatigue and has mild edema after recompensation. If you look at the right heart cath that we performed on the right-hand side, you'll see that the wedge pressure is slightly elevated with 18 millimeters mercury. The PAP mean, the pulmonary artery pressure mean, is 22 millimeters mercury, but no increase in PVR with 1 Wood unit, so no pulmonary hypertension. In this patient, RA mean is 5 millimeters mercury. I think that's due to his very good recompensation right now. He's on toracamide 20 and SGLT2 inhibitor. And if you calculate the TRI-score for this patient, it is a 4 out of 12, which puts him in the intermediate risk group with a predicted in-hospital mortality with 8%. But let's look at the pictures. So that's echo. It's a massive TR, 4 out of 5. It's clearly CIED related, as you see on the right-hand side of the screen. There's more jet in this patient, but I just brought the 2 slides to show you guys that the region where the lead is actually impinging, that there's a significant jet as well. If you calculate it overall, it's a ERA of 0.9, biplane VC with 18, TAPS is 14, FAC is 40%, and the 3DEF is 45%. So I think right ventricular function is not perfect, is impaired, but it's not terribly bad. There's also a part of functional atrial TR. It's, I think, mostly appreciated on the right bottom side of the screen, where you see that huge RA. There's not a lot of ventricular tensioning. It's a horizontal leaflet configuration and with a big AR. So I think atrial TR, functional TR, plays a role here as well. And then we mentioned the glide score before a couple of times. If you look at the gap we measured with 9 to 10 millimeters and the configuration of the jet in the bottom side of the screen, you probably can understand why we put 3 points in the glide score, 1 point for a gap over 6. Predominant jet location is diffuse. I think that's another point. And the TR on face jet is star-shaped. That's another point. The glide score does not calculate CID-related issues in, so I think that's something that we have to take into consideration as well. So that's our patient.
So thank you very much, Matti. I think very interesting patient, very different one from the previous one. Older patient, atrial component for sure, but also a pacemaker lead.
Yeah.
And what is extremely interesting is this patient has a little bit, in contrast to the previous one, has a little bit of pulmonary hypertension. So that's a configuration we see with a wedge that is a little bit 18, I think, if I correctly remember, a bit elevated. So that's a typical situation probably of FPEF associated with atrial and a CAD. So it shows you really what is the complexity there. It's not only one problem, it's probably 2 different clinical scenarios leading to severe TR. Maybe the same question as for Philippe before. Is this a candidate for you for edge-to-edge repair? What is your decision-making there? You showed us the glide score, very important, obviously. But what was your thinking in Cologne?
Yeah, thank you, Fabian. So I think glide score of 3 puts them in the intermediate risk group there as well. Reduce the TR here to less than moderate is, maybe 50% or less if you look in the publication. Also, there's a fair amount of posterior jet. The lead is not in an absolutely typical position. It's more on the lateral side of that posterior leaflet. We have a lateral, star-shaped jet as well. So I think that's not a case that we would prefer for edge-to-edge therapy, obviously.
No, I agree. I completely agree with that. And one of the other points that is interesting here, and was not the case in the previous one, is right ventricular dysfunction. It's not severe. It's a TAPSE of 14, so we have difficulties to look at right ventricular dysfunction. But obviously a patient with some damage of the right ventricle. So maybe I can ask to Philippe, in that situation, you were lucky, your patient did not have right ventricular dysfunction. This one has. Is that a criteria that will balance against replacement, for example?
Yeah, from all we have understood so far, we would think that for replacement, RV function is a little bit more at risk than for TIR. So you should start off with a better RV when considering replacement than when considering repair. TAPSE alone is not sufficient to tell you about the function of the RV, because TAPSE is the thing which goes down first, but at least in the intermediate stage, this is often compensated for by radial and circumferential contractions. So in these patients, a global assessment of RV function is needed. An ejection fraction, whether this is done on echo or CT or MR, doesn't matter, but an ejection fraction is important.
So thank you very much. We need to learn more about right ventricular function, but I agree, but probably not an exclusion in that situation. Now, Tiffany, the very difficult question for you, the patient has a lead and is dependent from this lead, actually, because of a 3rd-grade AV block and 99% of pacing. So if something happened to the lead, this patient may have a very serious complication. So would you consider extracting this lead, or what would be your discussion at your center in London?
Yeah, thank you, Fabian. It's a really important question, as a lot of these patients do have leads. We would generally discuss this with one of our EP colleagues within our MDT. There's always a discussion there. I think in this particular patient, slightly older age, lead may have been there for more than a short period of time. It's probably not somebody that would extract the lead in. And if you look at the actual mechanism, as Matti described, it's a mixed mechanism. So actually extracting the lead in terms of the TR wouldn't necessarily improve the situation. There's still severe RA dilatation.
In that situation, During the procedure, Matti, we need to be careful, obviously.
Absolutely.
Because if you touch the lead, you may have a problem. You may not be able to pace the right ventricle in an appropriate way if you are unprepared. So what are your strategies there? Are you preparing this procedure?
Well, that's a great question. I mean, obviously you have to be more careful with the device not to interact with the lead so much, but also I think it's very important that you take all the safety precautions that you do with the native case as well, without a lead. But what our safety regimen is that we always have transdermal pacing ready. So we actually try to pace externally the patient before the procedure, just for the case that you have a V block during the procedure, or in this case you do something to the lead that obviously the patient has 99% ventricular pacing percentage, and also you can pace over the wire. It depends on which part of the procedure you are. So we have everything ready for pacing over the wire. So we kind of have like a two-step safety procedure that we undergo, and I think that has served us very well. We've never run into problems there, so it's all very manageable. But I think it's very important point to consider.
Yeah, the message is here really get prepared to whatever can happen, because that can be a really critical situation where if you lose capture or you have a dislodgement of the lead during the implantation, and at different stage of the implantation, you will have different difficulties to be able to pace the right ventricle. So certainly something you should take into consideration. So before we look at the resolution of the case and what you did in that situation, I just would like to show you a few data that were just published or presented very recently. And obviously we are touching on risk of complication of transcatheter tricuspid valve replacement, which is obviously a little bit higher than compared to edge-to-edge repair. That's quite clear actually for bleeding complication, looking at the randomized controlled trial, but also, and we just mentioned this issue on the issue of pacemaker implantation that is obviously much deeper and much less prevalent in patients with edge-to-edge repair. So there is a need, and that's what we did, and also others did in the US, to look at the outcome of a transcatheter tricuspid valve replacement in a real-world environment, because these patients included into a randomized controlled trial are selected patients. And that's what we did. As you see here, the baseline characteristic of, we team up with 12 experience centers. Matti, you were part of it, and Philippe as well. With this baseline characteristic, you see that we were able to recruit 176 patients, quite a typical population of TR patients, majority of women, high comorbidity, high prevalence of atrial fibrillation as well. Good medical treatment, I have to say, and also some patients with comorbidities, renal and liver impairment. So typical population we are treating in the commercial experience so far. If you look at echocardiographic data again, the majority of patients are more than severe TR, massive or torrential. They have big coaptation gap, which makes them, for the majority of them, not eligible for edge-to-edge repair. And then in terms of etiology, we have a majority of secondary patients, some of them with primary etiology as well. And you see that on right heart catheterization, obviously very important, we perform this, and I think it's the case for many centers in all patients. You see that there is some degree, like the patient of Matti, of secondary pulmonary hypertension, which is generally due to left-sided problem that cannot be resolved, or heart failure with preserved ejection fraction. And then you see that the clinical result and the clinical success of this therapy is very high, with reduction of TR to none or mild in 98% of the patient. As mentioned by Philippe, residual TR is not a big issue. But you see also that we have some complication that are in a good range, compare favorably to TRISCEND, for example, with 9% of bleeding or 18% of pacemaker. Both numbers actually deeper than the one we have seen in the randomized controlled trial. NYHA class improve, obviously, and we were surprised to see already at 30 days an improvement in terms of renal function and an improvement of liver impairment as well. Some patients have complication, heart failure, acute heart failure was seen in about 5% of the patients, and these are patients that are going into the procedure maybe not completely optimized, or patients having right ventricular dysfunction, high NT-proBNP, or as you can see, also more than moderate MR. Other important complications that can happen are pacemaker implantation, and we need to be careful. That's something we did not discuss so far, but we need to be careful on discharging this patient early, because you see that some few pacemaker implantation or need for pacemaker can occur later and is in particular prevalent in patients with pre-existing conduction disturbances. There have been very recently at TCT the presentation of a very big population of patients, impressive 1,000 patient in the TVT registry with same result in terms of success, even better result in terms of mortality. You see 3% mortality at 30 days, less than 10%, the 10% in TRISCEND II in terms of bleeding, 7.9, and even a lower pacemaker rate than in our study in Europe. So I think all the indicators are actually very positive that this procedure is performing well, even in an unselected population of patients. And you can see finally an improvement in terms of quality of life that is very similar to patients having been enrolled in randomized control trial. We talk about pacemaker, and now there have been also a sub-analysis done on the outcome of patients having jailed pacemaker. No significant difference. I think that's an important message. So this patient can be treated with a valve, with a jailed valve. But on longer term, that's important. We have seen some small differences. Some patients had to have reintervention because of a lead-related complication. It was about 6% in TRISCEND II, 7%, so it's less than 10%, but can happen. And there is also some small changes when you look at this patient in a serial way, showing decrease in lead dependence and also in increase in capture threshold long term. So the question, before we go to the take-home messages, Matti, is looking at the data, would you change a little bit your approach of this patient that is pacemaker dependent or not?
Well, I think the data is very promising in terms of patients that are presented to you with the lead. I think the significant changes we've seen in the last publication you showed are absolutely not impacting the function of the pacemaker lead. It is something that you need to watch out for, and I think you have to particularly be very specific in planning these patients. You have to check the pacemaker before the procedure, before they leave the hospital. You have to get checkups regularly, 30-day, and then continue to follow these patients. But it would not change my strategy. For me, my take home from these slides is that a lead is something that you need to take care of and that you need to be aware of. But I don't think it's prohibitive for any kind of therapy that especially TTVR, that we want to offer these patients.
And Tiffany, will you discuss all your patients with your EP specialist at your center because of this data showing some possible complication in that situation, or how would you do that?
No, I mean, I agree with Matti. I think originally we probably would have discussed every single patient that we were doing that had a lead. But as we've gained more experience and really understand how to manage these and really understand what the longer term consequences are, it's more about being aware. But as Philip alluded to, it's not just the procedure itself, it's pre-procedure, post-procedure, being meticulous. So if anything needs to be picked up or adjusted or accounted for, you can do that, as long as you're very careful with the whole peri-procedural course.
So maybe some of the take-home messages from the data we have so far. So large population now treated commercially in the US and Europe. So with data that are at least comparable with randomized control trial. TR elimination had very positive consequences on symptoms and functional improvement, also end organ improvement. Patient with massive and torrential TR did benefit more. That it is in line with the data from Philip. And we have some predictor that we know, and I just mentioned, for adverse event. And finally, your point, Matti, patient with lead need to have particular attention, but this is not, they have not a worse outcome and can still be treated, of course, with this therapy. So let's maybe have a look, Matti, at what you did with your patient. And we are still expecting your question as well, because we have some minutes afterwards to discuss the content of this webinar. So Matti, what did you do?
All right. So we opted for TTVR in this patient due to the complexity of the tricuspid valve disease. And one of the workups that you need to do and that you need to perform is get a CT scan. And you see that the CT scan here is helping you a lot to understand the procedure even better. So you'll check for RA and RV working room, see that you have enough space for the system. Also, you get an impression on IVC offset, so how much angulation you later have to do with the system. But also, and most importantly, you get a very, very good impression on your annular size and shape. For example, if you look at the table on top, you'll see that you will look at the tricuspid annulus and the basal RV. And you see that the basal RV here is actually getting very ovally shaped, and it's a large SL dimension with 74 and 56. But the annular oversizing here with 9 to 10% or 9 to 11% is actually right in the sweet spot. That's where you want it to be. So we had no concerns with this patient and opted for a 56 valve in this patient, 56 millimeter EVOQUE valve. So I'll go back once. No, yeah, thank you. So that's the procedure. And, I put it on one slide because it was actually very uneventful. So you'll see that this is all home view. So you'll see on the top left of the screen, you'll see when we had the anchors 120 degrees flipped, you can see the lead, you can see the leaflet. It's a home view where, on the right-hand side of this, right upper corner is posterior anterior, left bottom side of the corner is septal and lateral. You'll see the leaflets are all ready to engage, and then we flip the anchors. All the leaflets were engaged at the specific side of the anchors. And on the bottom left side, you already see the valve is released. There's still that safari wire in place. That's not the lead, but you'll see the valve is really stable. The deployment on the right bottom side of the screen is super stable. You'll see the valve stays in position. The delivery system just moves a little bit more atrial. I actually like to see that because it meant that you had a lot of, enough tension on the system. So we were very happy with the deployment. The results, that's upper right and bottom left is immediately after procedure. You'll see that there's a little bit of a PVL on the septal side, not where that lead is, but where you had that most annular or RV basal diameter. The prosthesis was in a stable position with a pressure of a mean 2 millimeters mercury DP mean, so I think very promising. The IVC diameter decreased. We had elevation of S reversal in hepatic vein flow, so very happy with the result. And on the bottom right corner, you'll see the patient came in 1 month later, and you'll see that PVL actually it has a little bit of anterograde diastolic flow, but there's no PVL there. So again, super happy with the result, and the patient is actually doing great. So we're very happy with that procedure.
Excellent, thank you very much. Tiffany?
Fantastic. Yeah, well, actually, we've got some questions from the online audience now. Perhaps along the same lines as this particular case presentation, people are asking about RV function. How poor is too poor? Actually, there's not an actual cutoff that we're specifically looking at. It's just that we tend to perform TTVR in patients who perhaps do not have very severe RV dysfunction. Matti, what's your approach?
Yeah, I was just very much looking forward to pick your brains about this. To be honest, I think echo is really helpful, but I also look a lot at the right heart cath. If you have a low cardiac index, if you have high PVRs, I think that should be something where you should be really, really careful. Because those patients are usually sicker. They are, of course, in danger of right ventricular failure. You might prehab them as well and then redo the right heart cath. But I think those are my red flags. I think also, for severely impaired RV dysfunction echo. Fabienne, for you?
I like your answer a lot. I think the hemodynamic assessment is very important, and you see obviously if the left ventricular end diastolic pressure is very high in the patient on the cath, then you can probably assume that this patient have a poor right ventricular function. So that would be probably my pick at that time. Probably we need to do better to understand right ventricular function. I would be, and we can ask also Philip, that's a very good question about the futility, in particular regarding right ventricular function. But I would be a little bit concerned to implant in a patient where I see that several of the parameters we use are really in the severe reduced right ventricular function field, and I think that's where you should be a little bit careful about replacing. Philip, maybe you don't disagree with that.
I completely agree. It's hemodynamic, it is PVR, it is a prehab preparation of patients. But if one really wants to get a number, then I will be brave and I give a number, a TAPSI less than 10. I think this is really, really difficult. But as said before, look at the global function, look at ejection fraction. And there, I guess the number where it gets more complicated is 30, maybe 40, certainly 35%. Of ejection fraction, that becomes more difficult. Maybe another word about futility. We talk a lot about futility, but we haven't seen a single evidence or signal that there is a specific patient cohort, as long as they can be treated, that they will not benefit. So in other words, whenever we manage to reduce TR, we see symptomatic and clinical benefits, even when they present really late.
And we also see RV remodeling, Philip, right? I mean, so if we treat this patient successfully, we might actually see some of the remodeling that we actually wanted to see, right?
I agree, and that can happen in patients where the right ventricular function is really low, and where you would think that this will not recover. But obviously we need also to avoid having the dramatic case of right ventricular failure just after the implantation. That is very rare, but can occur as well. Tiffany, we have a few minutes more for questions.
Yeah, so there's a lot of interrelated questions, and I think we touched on it again earlier about the importance of right heart catheterization. I think we alluded to it because it's the combination of the RV dysfunction, the pulmonary pressures, and Philip mentioned that as well. We can't avoid doing right heart catheterization in these patients. Philip, could you support me on that? All these patients should have right heart catheterization?
You should do right heart cath in everyone. Absolutely. Absolutely. We want these procedures to be successful. We want them to be safe. We want to get the patient selection right. And a right heart cath has almost no risk. So why should we leave it out?
And one more question from the online audience. Actually, it's probably quite important because they've mentioned that we are mostly discussing or predominantly discussing the EVOQUE TTVR. And actually that is relevant because the only CE marked and FDA approved device available on the market at the moment is the EVOQUE. All other TTVRs are in research trials.
It's a good point, yeah, absolutely. So Philip, what are your expectations for other devices, replacement device approved in the future?
Several systems with very promising data, but they need to get approval. Then we will see what it means in real world. I mean, that's something we've seen already in EVOQUE, but no doubt there will be other systems which also will help us to treat more patients, and many of these patients as safe and as perfect as possible.
Thank you, Matti.
Yeah, just one comment maybe. So Tiffany, I'm curious, what's your discharge strategy for these patients? I mean, are these patients that you would discharge the same day or day after, or is that like an early discharge patient, or what's your strategy here?
Thanks, Matti. I think we're a bit of a way away from same-day discharging these patients at the moment. Certainly, the key is the post-procedural management and care. We tend to keep these patients in at least for a week, maybe 2 weeks, until they're therapeutic with their INR levels. We actually convert everyone to warfarin or coumarin post-procedure, just in the early phase to make sure that the valve endothelializes well without any issues.
I think that's a very important message. So we need to look for the patient. There can be a rhythm disorder occurring later than you think sometimes. So early discharge is probably not the way to treat them. And in particular, in your case, Matti, in particular, where you have a lead and a patient that is dependent on the lead, you need probably particular care. Are you EP involved then?
Well, the EP know, well, our EP guys definitely know if we do a case like this. We never had to call them in urgently. In this patient, for example, impedance stayed the same, threshold stayed the same, everything stayed the same, so no changes in lead function. But if you have something that you need to get treated, I mean, there are certain possibilities, leadless pacers, CS probes, stuff like that. And I think it's fair to your EP guys if you let them know beforehand that you might need their help. So definitely a case. I mean, in these patients, I think the heart team grows and grows. You need many specific and very well-trained staff to do this.
Thank you, Matthew. I think that's a fantastic closing remark. We need to work all together because of the complexity of what we are doing and the complexity of our patients. So it's an interdisciplinary treatment, and I think we have shown this, and we try to explain you what is important in the workup of this patient, but also as a preparation to the procedure, after the procedure, and some technical aspect also during the procedure. And I hope also that we could show you how much the evidence is growing, and how much data, new data are coming, and how much we are learning with this population of patients. So I want to thank everybody, Philippe Lourdes online in Mainz, Mathieu Adam and Tiffany Patterson here in Paris. Thank you very much for being with me. And I hope that you enjoy this webinar. Will advise your colleague to look at it on demand and follow future PCR webinar as well. Thank you very much for your attention. Bye-bye.